My name is Dave Cohn. I'm the Editor-in-Chief of Academic Emergency Medicine, and I'll be co-moderating the plenary papers with Deb. The standard ground rules apply: 10 minutes for the presentation, 5 minutes for questions and answers. If you'd like to ask a question, please come up to one of the microphones and identify yourself by name and institution. And please remember that this is an opportunity to comment on the speaker's research, not your research.
So with that, we'll get started with our first presenter, Dr. Grant Ennis, speaking on policy-driven improvements in crowding, system-level changes introduced by a provincial health authority and its impact on emergency department operations in 15 centers.
So I have to clarify, it's not 15 centers. There was actually a typo in the initial submission, so it's 14 centers. Having said that, I guess the first thing I have to say is getting a plenary slot at SAEM is just a highlight of a career, so I have to thank you for that. It's just a great honor to be up here. My presentation describes the impact of province-wide implementation of an overcapacity protocol on overcrowding at 14 hospitals. And I need to thank and acknowledge my collaborators in this, particularly Brian Rowe and Brian Holroyd from the University of Alberta, and Eddie Lang and Andrew McRae, who are transforming our research program in Calgary. I have no conflicts of interest, although I did have a small conflict when I tried to get Alberta Health Services to pay for my trip to Chicago. This thing that is often referred to as emergency overcrowding, I think is better referred to as emergency access block, which is the inability of a sick patient to get an emergency care space. The main cause of emergency access block is hospital access block, which is the inability of a sick patient who needs acute inpatient care to get an inpatient bed, therefore to be left boarding in an emergency department. Our hypothesis was that if we introduced a protocol which, under appropriate circumstances, pushes the right patient to the right place faster, that we could reduce access delays and reduce the number of patients boarding in emergency departments. A little bit of background information. Alberta, the province of Alberta, has 4 million people. It has one healthcare provider, Alberta Health Services. So this is an integrated management hierarchy, common performance targets, common protocols, and procedures, and integrated data system. Despite all this, for at least a decade, every year, access block and overcrowding has been getting worse and worse, despite multiple attempts to address it and a number of multi-million-dollar system-wide access and flow projects, none of which had any discernible impact on emergency overcrowding. So I'm going to make a somewhat longer and more interesting story very short by saying that in December 2010, we implemented an overcapacity plan in the province of Alberta. Some of you will recognize this as a map. Fewer of you will recognize it as a map of Alberta. We have one main city, Calgary, a smaller backwater to the north, 5 other cities, the most famous being Fort McMurray, which is the home of the Athabasca tar sands and the proposed origin of the Keystone XL pipeline, which we were hoping to use to ship dirty oil to the U.S. We implemented the overcapacity protocol at all of the 14 hospitals in these 7 cities in Alberta. What do I mean by overcapacity protocol? Well, actually, when I wrote the first draft of this and started pushing for implementation, I didn't call it overcapacity. I used Peter Viccellio's wording, which is full capacity protocol. But very, very quickly, the inpatient leaders I was working with perceived the true evilness of this protocol, and they said, that's not full capacity, that's overcapacity. So anyway, what the overcapacity protocol says is, if the emergency department is overcapacity by 10%, meaning we're treating 10% more patients than we have funded care spaces, and 35% of the ED stretchers are blocked either by an admitted patient or a referred patient who is waiting for an inpatient consult decision, and a sick patient arrives requiring stretcher-based care, then the most stable admitted patient in the emergency department just goes to the most appropriate inpatient unit on a no-refusal basis fairly quickly, i.e. 15 to 20 minutes. So the objective of this study was to evaluate OCP's impact on access to inpatient care, i.e. the length of stay that inpatients have to wait in the emergency department, and on the number of admitted patients boarding in the emergency department. So we looked at all emergency visits to 14 sites in these 7 cities. We looked at corresponding 8-month period from February 1st to the end of September, immediately in the year prior to OCP and after OCP. Primary outcomes were ED length of stay for an admitted patient and the number of boarded patients who were holding in emergency departments. Other outcomes included left without being seen rates and patient satisfaction. The data capture, data quality, integrity, data analysis was done by our Central Data Integration Management and Reporting Unit, and patient satisfaction surveys were carried out by the Alberta Health Quality Council. Because of the obvious weaknesses inherent in a before-after study design, we did a fairly simple analysis with minimal hypothesis testing. So the results, we studied about 580,000 visits prior to OCP implementation and about 620 in the post-OCP phase. So the volume rose by 5 to 10%, which we think is perhaps due to better access. Admission rates, ambulance arrival rates, and triage acuity levels were fairly constant. Main outcomes, ED length of stay for admitted patients fell by 33%, so that's about 6 hours. The mean number of admitted patients being held decreased by 46%. That's about five patients per department every morning. Other outcomes, we had very modest improvements in wait times to physician left without being seen rates. We did see a 0.4% increase in revisit rates for hospitalized patients who were discharged. So for every 250 inpatients discharged, we had 1 additional revisit to the hospital. This graph shows ED lengths of stay in hours for the 14 sites before and after implementation of OCP. You'll see that there's 5 sites that are outside the box. These sites, as it turns out, were already achieving provincial flow targets prior to OCP implementation, therefore didn't actually see a benefit. The benefit was concentrated in the 9 sites that were substantially access blocked prior to OCP implementation. So for example, towards the right side of the box you see SCH had a length of stay of over 30 hours for an admitted patient, which fell to around 20 hours after protocol implementation. This graph shows the number of boarded patients by site before and after, actually a larger improvement there. This table is site-specific data for the 9 access blocked sites, and I'll just get you to focus on the right lower corner, which shows an average of a 7.9-hour reduction in ED length of stay for the 66,000 admissions during the post-OCP period. So if you do the math, that adds up to 522,000 hours of not waiting to get into your inpatient bed, or 522,000 hours of ED stretcher time that's freed up for arriving patients. This just shows the roughly 50% reduction in boarded patients after implementation of OCP. So I've described the main benefits, the primary outcomes already. As I mentioned, we did see a 10% increase overall in volumes, from 5 to 20% depending on the site. We think that's because patients could actually get into the departments afterwards. We did a similar implementation of a protocol in Vancouver several years ago, which showed a similar roughly 40% effect size in terms of reducing length of stay. In this study, the Health Quality Council concluded that there was a small improvement in patient experience after OCP. I think the way that this works, I believe that protocols like this increase accountability for patient care by, to some extent, removing the ability of programs to address their demand capacity challenges by merely closing the door and leaving the patients outside. I think that it enhances appropriateness, and what I mean by that is, to some extent, it pushes sicker patients into the front door and perhaps at the same time pushes less sick patients out the back door. Most important, I think it's an evolutionary stressor, and when patients are going to land in your lap, I think it forces you to look at how are we going to develop internal solutions for these access challenges. Some limitations, there's obvious limitations to a before-after study design, but given the nature of the implementation, which I would be happy to discuss, this was the only study design that was feasible. This was implemented in perhaps a unique system, and it may be difficult to implement in other settings. We didn't capture all of the relevant outcomes. I'm now working on a link with vital statistics to get mortality data, but I don't have that yet. We didn't look at things like sick time and overtime for nurses, or total system cost, or things like MRSA infections. We didn't adjust for co-interventions or temporal trends. My time is out, so I hope somebody will ask a question about this. And when I say we aren't able to report compliance with OCP triggers, this is the ultimate in terms of an effectiveness, real-world implementation. This protocol landed on 14 hospitals, and it was implemented differently in all of them. So conclusions, the OCP implementation had large reductions in the hospital access block and in the number of admitted patients boarding. We also found modest improvements in wait times, left without being seen rates, EMS offload success, and patient experience. Many of those described in other abstracts at this conference. Thank you.
This paper is now open for questions, and please remember to come to the mic and introduce yourself and your institution.
From Australia. Very nice paper, thank you so much. I'd love to take it back to my country. And what were those temporal trends to which you alluded?
Okay, excellent question. Okay, he asked about temporal trends and confounding. And so obviously in a before-after study, and particularly in an administrative study of this nature, there's a lot of potential confounders that you don't measure, can't measure. And so the two things that reassure me about this data set are first that over a decade, every single year, regardless of capacity enhancements, changes in processes, changes in programs, very expensive attempted system interventions, every year things were getting worse up until December of 2010. So I think that if we were able to adjust for temporal trends, that the effect size would probably be larger than what we found. The other thing that reassures me is that despite, I'd say, limited ground preparation in 14 different settings, we found the same thing at all sites. So I think it was implemented differently everywhere, and yet, despite different contexts, we had significant success in all of the sites that had access block problems.
Adam Singer, Stony Brook. Great study. I have a question though. At Stony Brook, our experience has been that about a quarter of the patients, when they go upstairs, immediately find a bed, and another quarter within an hour have a bed. Did you look to see what happened once the patients got upstairs? And the other part of the question is, one of the criticisms we've had is, have you looked at the impact of the full capacity protocol on the inpatients? Did you try to look how did that impact them?
Okay, so the first question, I guess, is how long did they stay in the hallways? And the answer is I don't actually have that data for the 14 sites. I can't tell you. I know they don't stay in the hallway very long. And interestingly, since this thing was implemented, I've kept my head low. And I've actually had no complaints from any department heads. In the city of Calgary, we've had no surgical delays, no cancellations, fewer patients waiting in ICU. Some of the inpatient outcomes seem to actually be a little bit better. And the bizarre thing in Calgary is that we went from using 22.9 so-called overcapacity beds prior to OCP implementation to 11.9 beds per day after OCP implementation. So somehow we're using yet less OCP beds. So it seems like something fundamental has happened in flow, and I'm seeing all kinds of projects from inpatient services now. So I think that outcome is positive. Length of stay for inpatients has fell by like 4 or 5 hours, so less than a day. As I say, we don't really have a big signal in terms of harm with high numbers of bounce backs. So I don't expect when I get mortality data that we're going to see anything there either.
Okay, thank you for an excellent presentation. The next paper is entitled Prevalence of Non-Convulsive Seizure and Other Electroencephalographic Abnormalities in Emergency Department Patients with Altered Mental Status, to be presented by Dr. Shahryar Zatabchi from SUNY Downstate.
Oh, here you go. I got it. Sorry.
Close enough.
All right, something happened. That's okay. Do you have the... I'll just work right off. All right, keyboard. Good afternoon. As mentioned, the title of this study is Prevalence of Non-Convulsive Seizure and Other Electroencephalographic Abnormalities in Emergency Department Patients with Altered Mental Status. This was an NIH-funded study, a collaborative effort between Department of Neurology, Emergency Medicine, and Biosignal Company. Altered mental status in form of confusion, lethargy, agitation, coma, unexpected psychosis, etc., constitute about 4 to 10% of emergency department visits in the United States. And according to the literature, about 4 to 10%, according to literature, about 30% of AMS cases occur because of neurological etiologies, such as non-convulsive seizure. Previous literature have shown that about 8 to 30% of patients with altered mental status have non-convulsive seizure, but most of these studies have been conducted in non-ED settings such as ICU. Unfortunately, more than half of the cases of non-convulsive seizure are diagnosed more than 24 hours after presentation to the emergency department. And remember that we are talking about a disease with very high mortality and morbidity. For example, 50 to 60% of patients with non-convulsive status epilepticus die. And from those who survive, only 20% regain complete functional neurological function. So why do we miss these non-convulsive cases? First, the only test that shows us the functional status of the brain is EEG. And in addition, in non-convulsive seizure, there is really no sign or symptom or no clinically apparent movement that can indicate seizure. So the only test that can diagnose non-convulsive seizure is EEG. Unfortunately, we face several challenges for using EEG in the emergency department. It is very difficult to bring a bulky EEG machine to the patient's bedside, especially in overcrowded emergency departments. The use of cardiac monitors and other electronic devices create a hostile electronic environment that could interfere with EEG recording. And lastly, in order to have a 24-hour EEG service, you need professional expertise. In fact, in our institution, only 2% of EEGs were ordered from the ED, and only a small fraction of those EEGs were actually done in the emergency department. So we designed this study with two objectives. First, to identify the scope of the problem by estimating the prevalence of non-convulsive seizure and other EEG abnormalities in emergency department patients with altered mental status. And the second objective was to estimate the diagnostic utility of microEEG in identifying the same EEG abnormalities. This is a standard EEG with the standard electrodes, and this is microEEG, a portable wireless miniature EEG device that has some unique characteristics that could help us overcome the hurdles limiting the use of EEG in the emergency department. But for this presentation, I'm only reporting the results of the first AIM, and this AIM and the microEEG part will be presented in a moderated poster session on Saturday. So we included every patient with altered mental status, 13 years of age or older. If the patients had an immediately identifiable and correctable cause for their altered mental status, they were excluded from the study. Patients who couldn't undergo EEG for any reason, such as those with severe scalp injuries, they were excluded. Hemodynamically unstable patients, uncooperative or combative patients were excluded from the study for obvious reasons. We also excluded patients who had overt seizure in the emergency department. But if the emergency physician felt that the post-ictal period was prolonged, we included those cases. So patients with altered mental status were identified by the ED physician. If they couldn't find an immediately correctable cause, they notified the EEG technician. The EEG technician started recording EEG within 30 minutes. After EEG was recorded, it was transferred to a web-based server where an on-call neurologist was notified. This on-call neurologist was not blinded to the clinical information. He had access to clinical information. And after reviewing the EEG, the neurologist called back the ED attending and reported the EEG results within 1 hour. We enrolled 261 patients. Enrollment occurred 24 hours a day, 7 days a week, and the consent requirement was waived by the IRB. The median age for our patients was 60, and 54% of our patients were male. And you can see the presenting symptoms here. 10% of our patients had acute head injury, 39% had history of seizure, 28% had neurological findings, and 22% of them had PET CT findings. And 85% of patients were admitted. 78% of the EEGs were reported abnormal. These abnormalities included non-convulsive seizure in 7% of our patients. The seizure was in form of non-convulsive status epilepticus in about 2% of cases, non-convulsive seizure without status in 2%, another 2%, and non-convulsive seizure in context of burst suppression in 3% of patients. 13% of our patients had epileptiform waves that indicate high risk for a spontaneous seizure. 58% of patients had slowing, which generally indicate localized or global cerebral dysfunctions like what we see in encephalopathies. And 20% of cases were reported normal, with 2% as uninterpretable. We divided our patients based on their EEG reports into different categories: normal versus seizure, and normal versus any EEG abnormality. And we did a univariate analysis looking at different variables such as age, gender, history of seizure, neurological findings, head CT finding, head injury, and other variables. The only variable that was significantly different between the groups was age. We also performed multiple logistic regression in order to identify the variables that could predict the outcome of abnormal EEG. And again, age was the only factor that was predictive of the outcome with an adjusted odds ratio of 1.05. From the findings of this study, we can conclude that the risk of non-convulsive seizure and other EEG abnormalities in emergency department patients with altered mental status is high, and EEG is a necessary test in evaluation of these patients in the emergency department. Also, age is a strong risk factor for having abnormal EEGs. I must add that even though our study showed that 7% of patients had non-convulsive seizure, we believe that this number, or the real number, is actually higher. Because remember, EEG is a 30-minute snapshot of the brain. So a lot of patients can have seizure either before the EEG or after EEG. And there's no way to capture all the non-convulsive seizures without continuous monitoring. So out of the last 100 patients that we all have seen in the ED, 7 of them could have had seizure, and there's a good chance that we missed most of them. And we are talking about the disease with a very high morbidity rate and mortality rate, a disease that is time sensitive. And just like any other time sensitive entity, it is our responsibility to take charge and to make sure that we diagnose this on a timely manner and manage them properly. We have to fight to make the EEG part of ED armamentarium, and if we have to learn how to interpret EEGs, or at least familiarize ourselves with EEG interpretations, then we'll do that. We'll add that to the list that includes ultrasounds and CAT scans and other things. Thank you. Yes, so the immediately correctable, the question is how long did we give the attending to decide whether the causes are identifiable or not. Usually within half an hour or 1 hour, with the shot panel, with the finger stick, with the chest X-ray, we could decide whether the patient has hypoglycemia, hypothermia, hyperthermia, or opioid overdose, those kind of things. Yes?
Jim Meyer from Hennepin County. It seems like the degree of altered mental status would correlate really well with your likelihood of finding an abnormal finding. Were you able to quantify how altered the subjects in the study were?
The question is, did you look at the correlation between how altered the patients were and the risk of having EEG abnormalities? No, we did not do that. We did not look at the focus of the study was just to get a rough idea about the prevalence of non-convulsive seizure in the ED. So we did not did that correlation.
Sal Carrier from the University of Louisville. I have a question about whether the patients who had prior history of seizures, whether they were on anticonvulsants or those that may have been brought in with the ambulance crew, have been treated with benzodiazepine, and how this might affect the EEG tracings and interpretation.
Well, thank you for the question. I think if everyone kind of... Yeah, we looked at the number of patients who were on anticonvulsive, the patients who received anticonvulsive in the field, and those who received anticonvulsive in the ED. And in our logistic regression model, we use those variables, but none of them were directly predictive of abnormal EEG at the end.
So do the neurologists think that if a patient is therapeutic on phenytoin or Tegretol, that would affect the EEG or not? I guess that's one of the questions I have. Would you have a patient show an abnormal EEG, yet they're on a therapeutic level, have a therapeutic level of anticonvulsant?
Right. The question is if the patient is on anti-epileptic medication, does that affect the EEG recordings? And the answer is yes, but if, as I said, the neurologist who interpreted the EEGs and what we used their reference standard, he was aware of those, for the medications that the patient was on. So they did not interpret those as abnormal.
Last question.
Intermittently.
But first, a really nice study, and thanks for doing it. My question relates to the abnormalities. It seems like the non-convulsive status is the key abnormality we have to pick up. Do you have a sense if those were clustered amongst people with pre-existing seizure disorder, or there are predictors for probably those probably more important findings than the generalized slowing?
Very good, thank you. So the question is, how many of the non-convulsive seizures occurred in patients who had previous history of seizures? I think about 60% of non-convulsive seizures were in patients who had previous history of seizures, and 40% of patients with those with non-convulsive seizure had no previous history of seizure. And according to the literature, these patients who do not have history of epilepsy or do not have history of seizure in the past, they are more likely to be resistant to treatment, and they are more difficult to diagnose. So even though most cases are in patients with history of epilepsy, we still have the challenge of diagnosing those cases that have no previous history. And in addition to just non-convulsive seizure, other types of EEG interpretation, even slowing, can help you in certain diagnosis. The idea is that because the list of differential diagnosis for altered mental status is so wide, EEG can help you narrow the differential diagnosis by ruling out and ruling in certain diseases.
Thank you very much.
You're welcome.
For those whose legs must be getting tired standing in the back of the room, we do have some nice seats up front for you. The next speaker is Dr. Prasad Mahajan, speaking on RNA transcriptional profiling for diagnosis of serious bacterial infections in young febrile infants.
Good afternoon. On behalf of PCARN, we are presenting RNA transcriptional profiling for diagnosis of serious bacterial infections in young febrile infants. I have no conflicts of interest to disclose. Fever is the most common reason for pediatric visits to the emergency departments, and most febrile children will have a non-bacterial etiology. A small proportion will have serious bacterial infections, which includes bacteremia, bacterial meningitis, and UTI. Infants less than 60 days of age are at highest risk for SBI, which is estimated at somewhere between 6 to 10%. The diagnosis of SBI requires blood cultures or cultures which are the reference standards. But there are several limitations to using blood cultures as a reference standard because of a high false positive rate due to the growth of contaminants, unknown false negative rates, and prolonged time to positivity. Hence, an alternative approach to pathogen identification must be explored. One such alternative is to quantify the host response by measuring gene expression with microarray techniques. different microbes are recognized by pathogen-specific receptors and stimulate a distinct immune response. I'm going to see if I can get the pointer here. I guess not. In this graphic, the immune response to microbe A is different from immune response to microbe B and different from microbe C. These distinct immune response patterns can be identified by measuring the specific expression profile, also called as the RNA signatures. This expression profile can be demonstrated and measured in different ways and will be explained in subsequent slides. For instance, bacterium versus a virus will have a different mRNA expression pattern, and that can be demonstrated in several ways. The main objective of our study was to define diagnostic RNA biosignatures of serious bacterial infections, SBI positive, and non-bacterial infections, or SBI negative, in febrile infants younger than 60 days of age in the ED using RNA microarrays. We conducted a prospective observational cohort study in a convenient sample in 22 participating centers in PCARN over 2008 to 2010. Infants less than 60 days of age with fever who were being evaluated for SBI with a blood culture were eligible for inclusion. We applied exclusion criteria including prematurity, overtly septic appearing infants, and immune compromised states, amongst other criteria. We defined SBI positive infants as those with bacteremia, UTI, or bacterial meningitis. We defined SBI negative infants as those with negative bacterial cultures or growth of known contaminants on blood, urine, or CSF cultures. Some patients in both groups actually were tested for viruses. Clinicians recorded EL observation scores that described the clinical appearance of the infant, and patient demographics and routine lab results were recorded in a standardized manner. For expression analysis, we collected 1 ml of blood from each enrolled patient. Results: we approached 2,820 febrile infants who were less than 60 days of age. We consented 82% of these infants and were successful in obtaining blood in 1,883, or 82% of the consented infants. The rate of SBI was 8.7%. The rate of bacteremia was 2%, the rate of UTI was 7.4%, and the rate of bacterial meningitis was 0.3%. Of note, the rates of SBI, including bacteremia, UTI, and bacterial meningitis, were consistent with the rates that are previously reported. For expression analysis, we selected 327 samples. 94%, or 306 of these samples, passed all quality controls. There were 26 healthy controls and 282 febrile infants, which included 90 samples of patients with SBI and 192 samples of SBI negative infants. This is a heat map of RNA biosignatures. In this map, each column here represents one patient and each row represents one gene. So the group on the far left represents gene expression patterns of afebrile, normal, or healthy infants. The group in the middle represents gene expression patterns of SBI positive infants. Please note that they include patients with bacteremia and UTI. And the group on the right represents gene expression patterns of SBI negative infants, which includes infants who have proven with influenza virus infection, enteroviral infections, those who have been tested as viral negative, and those who did not have viral testing performed. So using non-parametric tests, we identified 2,732 genes and 308 samples, which were differentially expressed between healthy controls, those who were SBI positive and those who were SBI negative, as shown in this heat map. The yellow color represents the median expression level in healthy afebrile groups, while the red color represents overexpression of the genes when compared to the controls, while blue color represents underexpression. To simplify the clinical application of this expression analysis, we conducted something called as the modular analysis. Each individual module is a group of genes that share common biological functions and are co-regulated. A modular map is shown at the bottom. In this map, the light blue squares represent the position of the interferon-related genes, and the brown circle represents the position of the inflammation-related genes. In the upper modular map, overexpressed genes are displayed in red, while underexpressed genes are displayed in blue. In the SBI positive modular map, you can see an inconsistent expression of the inflammation of the interferon-related genes and an overexpression of the inflammation-related genes. While in the SBI negative group, you see an overexpression of the interferon-related genes and an inconsistent expression of the inflammation-related genes. To confirm the results of the modular analysis, we then looked at modular analysis by individual patient. Again, each column represents one patient, and each row represents the expression of genes in these modules. We can see that the SBI positive patients consistently expressed inflammation-related genes, and almost no patient had an overexpression of the interferon genes. On the other hand, SBI negative patients had an inconsistent expression of the inflammation-related genes and a relative overexpression of the interferon-related genes. We then applied a third type of analysis called as the KNN algorithm to identify genes that discriminate SBI positive and SBI negative infants. The KNN algorithm identified 85 classifier genes that discriminate between the SBI positive and the SBI negative patients with an 87% accuracy. To decrease the influence of patient outliers on the selection of these genes, we tested the accuracy of these 85 classifiers on an independent set of patients, which included SBI positive and SBI negative, and had a similar accuracy of 85%. Conducting a similar analysis, but now limited to patients with bacteremia alone as compared to those who were SBI negative, the KNN algorithm now identified 66 classifier genes that differentiated the two groups with nearly 90% accuracy. Finally, we examined the modular analysis of individual SBI patients. These are SBI positive patients who demonstrated an unexpected RNA expression profile. These patients included 3 patients with strep viridans, which did not demonstrate an overexpression of the inflammatory genes and therefore are most likely to be contaminants. The patient with a documented viral and bacterial co-infection also had an unexpected pattern. They had an overexpression of the interferon genes, but did not have an overexpression of the inflammation-related genes. And similarly, there are some patients in the UTI group that showed overexpression of the interferon-related genes and most likely represent a viral co-infection. There are some limitations to our study. It was a convenient sample, and viral testing was not performed consistently across febrile infants. But our study also has some strengths. It is a large sample size, and it is a geographically diverse cohort. And further analysis to better define SBI biosignatures is presently being conducted. In summary, RNA biosignatures in SBI positive infants are more homogeneous and are defined by overexpression of inflammation genes and relative underexpression of interferon genes. RNA biosignatures in SBI negative infants are more heterogeneous, with an overexpression of interferon genes and an inconsistent expression of inflammation genes. In conclusion, gene expression analysis using RNA biosignatures confirms the potential of this technology for distinguishing young febrile infants with SBI from those without bacterial illness. With further refinement, this technology may replace cultures in the future as the reference standard for diagnosing SBIs. I would like to acknowledge all the participants in this study, and particularly my 2 co-principal investigators, Octavio Ramilo and Nate Cooperman from UC Davis, who has been my mentor in this study. And I'll be happy to take any questions.
This paper is now open for questions.
Hello, Chuck Ahrens, University of North Carolina. Excellent study. Thank you very much. I have a couple questions. The first one just has to do. It would be no more than 2. Amy's awesome, her group of 2 have been looking at genomic expression patterns between viral and bacterial infections, and actually did a series of experiments where they induced viral infections and followed genomic signatures over time. What they found is that there's some very interesting changes that occur prior to symptoms and then would change afterwards. So my first question to you is, what was the timing of these signatures?
So the timing was when they presented to the ED. because we wanted to make it clinically relevant, when the patient presents to the ED, the clinical question is whether the patient does or does not have a bacterial infection. So we drew the blood at the time of presentation when they were being investigated for other tests, other screening tests.
One of the big challenges in terms of diagnosing infants in particular is those who aren't febrile. And distinguish between those with bacterial infections who don't exhibit fever. Have you looked at a control group, and have you decided to try to look at that challenge?
Right, good question. We do have afebrile controls, which is against which we measured the expression level. We do not have a set of individuals who are bacterial infection positive but who were afebrile at presentation. And the reason was the clinical dilemma for most clinicians is when a child presents with fever and has no other source and otherwise appears well appearing, then whether the patient has a bacterial infection or not. And that was our premise. But kind of related to your question and to the first question that you asked, we do not have the because no one can tell you at what time point did the illness start in that particular patient. One proxy to that, if we assume that the onset of fever is the onset of illness, for instance, then we are collecting data on the duration of fever. But again, we do not have infants who are bacterial positive but do not present with fever.
My name is Brian Kendall. I'm a medical student. Thank you very much for presenting. That was very interesting. One of the questions I had, though, is if this is to replace cultures, is this technology able to determine sensitivity to different antibiotics?
So the premise of our study is that because the blood culture, the reference standard itself is not very good, that's why it is not called as a gold standard, we are hoping by explaining the physiology of the illness, and if we compare with a larger cohort with a true positive infection or proven bacterial infection, then we could potentially replace blood cultures. And that is what some of the signatures showed. I showed the slide with the strep viridans. That patient typically is considered as a contaminant and fell in the contaminant group. And your other question was whether it can. So it won't essentially replace as of now, but as we make these biosignatures more robust, and when we put into our database a larger number of SBI positive or true positive infections, then we potentially, it has a substantial potential for replacing blood cultures.
Last question. Hi, Heather Strike from University of Virginia. Thanks for this presentation. I just wanted to know what the turnaround time was for this test. If the cultures are 48 hours, and that's one of the limitations of it, is this significantly faster, and can it sort of change things real time for us?
Right now, so the way the study is being conducted, because it is being conducted across 22 sites, the turnaround time is not very fast because all these samples are being batched and analyzed. But the expectation is in the near future, as we make more robust signatures, that we will be able to potentially define a set of genes which could be discriminatory. That was the KNN algorithm, which there is always a potential that it can be placed onto a PCR chip, which could have a faster turnaround time and definitely shorter than 48 hours.
Okay, thank you very much. Our next presentation is entitled Saving Maternal, Newborn, and Child Lives in Developing Countries, Evaluation of a Novel Training Package Among Frontline Health Workers in South Sudan. Presenting will be Brett Nelson from the Massachusetts General Hospital.
Thank you for this opportunity. It's a pleasure to be with you and to represent the Division of Global Health at Massachusetts General Hospital. We wanted to share with you some of our work on maternal, newborn, and child survival. First, disclosures. I have no commercial relationships or conflicts of interest to disclose. Funding sources for this initiative were from the Ministry of Health of South Sudan, the Multi-Donor Trust Fund for South Sudan, as well as Massachusetts General Hospital. Over the next 10 minutes, I'd like to briefly discuss maternal, newborn, and child health in South Sudan, and then focus on the Maternal, Newborn, and Child Survival Initiative that we developed in partnership with the Ministry of Health. We'll draw a few conclusions and then discuss next steps. So to begin with, many of you are very well aware that South Sudan represents one of the most underdeveloped countries in the world. It has been suffering from 40 to 50 years of nearly continuous conflict. And this conflict has greatly disrupted millions of lives, livelihoods, and health infrastructure. And as a result, South Sudan sadly suffers from the worst maternal mortality in the world, and among the worst newborn and child mortalities, where it's more likely for a girl to die in childbirth than to graduate from elementary school. And 1 in 7 children will die before the age of 5. Fortunately, there's been a relative peace, and independence was established in July of 2011. So there's a lot of hope and optimism in South Sudan. And fortunately, there's some great initiatives that are being implemented to reduce the mortality rates. One in particular is this partnership between Massachusetts General Hospital and the Ministry of Health. The Maternal, Newborn, and Child Survival Initiative. Its aim is to train and equip community-based frontline health workers to appropriately prevent, manage, and refer the leading maternal, newborn, and child emergencies in South Sudan. To accomplish this aim, we are working with frontline health workers. These are the wonderful traditional birth attendants, community health workers, community midwives, and others, who are currently providing actually 90 to 95% of the deliveries in South Sudan. And these are occurring outside of health facilities. These frontline health workers are typically non-literate, without previous medical training, and frequently without previous education. So after a formal multimodal assessment in partnership with the Ministry of Health, we developed an evidence-based, innovative maternal, newborn, child survival package to build local capacity. This package contains 3 essential components. First is participatory training course. Second are pictorial checklists. Third, reusable equipment and commodities. The program has been implemented using a training of trainers model to build capacity and expand the approach. I'd like to just individually talk about each of these components, beginning with participatory training. So we developed a 5-day training course for our frontline health workers. It provides them with the essential skills and knowledge to address the main killers of mothers, newborns, and children in South Sudan. We also have an 8-day training course for our local master trainers. This course contains the same information. However, it also contains several days of information on adult learning techniques, participatory teaching, role-playing, supervision, and just the logistics of the program. To facilitate the program, we also provide maternal and newborn mannequins, such as the one you see here. This is the new Lair doll, neonatally, which is very affordable, can be inflated with water or air, and has functional lungs and umbilical holes. We also provide a 140-page trainer's manual that we developed and a large illustrative flip chart that is used for teaching the trainees. This is one of our colleagues, Melody, in the audience, training a couple of our master trainers in essential skills. The training is very participatory, hands-on, interactive, and we like to think it's also a lot of fun. The second essential component of the maternal, newborn, child survival package are pictorial checklists that will guide the largely non-literate frontline health worker through his or her work. These checklists include, for example, healthy pregnancy and antenatal care visits, danger signs during pregnancy, danger signs during labor, postpartum hemorrhage, newborn resuscitation, screening for child malnutrition. Here are 2 examples of those checklists. On your left is the 2-sided antenatal care visit checklist. The frontline health worker will use with each pregnant woman, talking about the importance of, for example, the mosquito bed net, or 2 tetanus toxoid vaccinations, or anti-malarial medications, the importance of having an emergency transportation plan, good nutrition, and blood pressure screening. On your right is the newborn resuscitation checklist, which is actually distilled from some wonderful programs like NRP and the new Helping Babies Breathe program. And we've distilled this down to 5 essential steps. Here are 2 of our master trainers, Josephine and Feli, practicing with one another on teaching the checklists. The third essential component of the MNCS package are reusable equipment and commodities. In South Sudan, supply lines are nearly non-existent, and so we found it necessary to actually provide the essentials tools directly to the providers. Here in this picture, you'll see some of the equipment that's provided to trainers as well as the equipment provided to the trainees. Let me just show you the list of equipment provided to the trainees or the frontline health workers and highlight a few. They receive a bag mask device for newborn resuscitation, a bulb suction, mid-upper arm circumference tape for screening for childhood malnutrition, and one that we're really excited about is the intrauterine balloon. It's this simple device made up of a Foley catheter upon which a condom is tied, and then you use a large syringe to fill the device with clean water. This intrauterine balloon can be used to address uncontrolled postpartum hemorrhage. So let me give you some of the results to date. So beginning in November of 2010, we have since trained just over 70 master trainers and just over 700 frontline health workers in 7 of the 10 states in South Sudan. Monitoring evaluation is an important component of all programs, and it's an ongoing component of all trainings in this program. We also did a focused M&E trip in May of 2011, and most recently we completed a field-based intrauterine case study looking at the balloon effectiveness and safety. Here are some of the results for knowledge and skills tests amongst the trainers and the trainees. The trainers you'll see in the first line have good mastery of the content, going from 62 to 92% mastery after their training. Frontline health workers were assessed via skills tests, and their mastery of maternal skills went from 21 to 83. However, at 3 months follow-up, when we did a field-based assessment, we did find a fall-off on that mastery of skills. With regard to newborn skills, it showed a similar pattern, going from 41 all the way up to about 90% mastery, but then had a significant fall-off to 45. All this is suggesting to us that frontline health workers can learn and master this knowledge. However, it does require refresher trainings. With regard to satisfaction and practices, we surveyed the first cohort of frontline health workers, and all of them were either very satisfied or somewhat satisfied. All of them had regular use of the equipment and checklists, and they were using it on average of 4 to 5 times per month, which is on par with the number of deliveries per frontline health worker. What we were most excited about, however, was that 78% of frontline health workers were now more likely to refer their patients to facilities. With regard to outcomes, we were able to track 244 deliveries in this first cohort of trainees. The maternal outcomes amongst these 244 deliveries included 6 mothers that had postpartum hemorrhage, 4 of whom required the intrauterine balloon and referral. But we're happy to find out that there were no maternal deaths within all 244 deliveries. Just using the current maternal mortality ratio estimates for South Sudan, we would have predicted about 5 deaths. With regard to newborn outcomes, we had 14 newborns that required resuscitation, and 11 of whom were successfully resuscitated and survived, for an overall crude newborn mortality of 1.2, which is far below that of the current estimates. We held some focus groups, and just major themes include high satisfaction, regular use of the equipment, and increased referrals. Just as one example of the comment that we heard again and again, referrals are better than before. In the past, we would tell women you need to go to the health center, but they would not want to go. Now we show them the checklist and they will go. Lastly, just a couple of months ago, we also performed a field-based assessment of the intrauterine balloon using a case study design. We identified 11 cases, all of whom were experienced uncontrolled postpartum hemorrhage after initial steps and required placement of the balloon. Many of these patients were already unconscious at the time of placement, suggesting that they were severely ill. Fortunately, 10 out of the 11 patients receiving the intrauterine balloon survived. So we find, considering that these patients were severely ill, that referral was very distant to health facilities. We find this early data very encouraging. So in summary, there are significant maternal, newborn, and child health emergency needs in South Sudan and in many developing countries. Fortunately, there are very simple, cost-effective tools that can save the overwhelming majority of these lives. From our data, we know that community-based frontline health workers can acquire the essential knowledge and skills to save these lives and to increase referrals to health facilities. However, we also know that refresher trainings are clearly needed, and new modules are being developed, including modules for family planning and prevention of mother-to-child transmission of HIV. I'd like to recognize my colleagues in the Division of Global Health and Human Rights at MGH, as well as to thank our colleagues in South Sudan for all of their support. Thank you.
This presentation is open for discussion. I have a quick question for you about how this all got started, seeing as how South Sudan has been in existence for less than a year. I'm assuming that these relationships had been launched prior to the independence. Was there a pre-existing relationship with the earlier government, and how did that work politically?
That's correct. Fortunately, Massachusetts General Hospital has been involved in South Sudan since 2009 was our first visit, and we were there by invitation of the World Bank leading up to independence. Fortunately, there's been some security and peace, relative peace in South Sudan for the last several years, culminating in the independence in July of 2011. So we've had an opportunity to build a relationship, work with the Ministry of Health, do a number of needs assessments, as well as education at the three teaching medical schools.
Okay, thank you very much for this presentation.
Our final presentation will be whole blood lactate kinetics in patients undergoing quantitative resuscitation for septic shock by Dr. Alan Jones.
Dr. Howery, fellow members, I'd like to thank the Society for the opportunity to present our work. My name is Alan Jones from the University of Mississippi, and I'm going to talk to you today about whole blood lactate kinetics in patients undergoing quantitative resuscitation for septic shock. I'd like to thank my co-authors for their contribution to this work. By way of disclosure, I'm a member of the Board of Directors of the Society for Academic Emergency Medicine, and I receive grant support from the National Institutes of Health. Septic shock mortality remains high even in modern day. And previously, early resuscitative bundled care has been shown to decrease mortality in septic shock. However, the ideal early sepsis resuscitation endpoints remain controversial. Recently, lactate clearance has been shown to be of value as an endpoint. However, the optimal lactate kinetic parameters of resuscitation are presently unknown. The objective of our study was to compare the association of whole blood lactate kinetic parameters with survival in patients with septic shock undergoing quantitative resuscitation. This was a pre-planned secondary analysis of a randomized controlled trial of ED-based early sepsis resuscitation that's been previously published. Written informed consent was obtained from all patients or their surrogates, and the trial was registered on clinicaltrials.gov prior to initiation. The trial took place between January 2007 and January 2009 in 3 large urban tertiary care emergency departments in the United States. All the EDs were staffed by EM residents and board-certified EM attendings. We included patients who had suspected infection, 2 or more SIRS criteria, and either hypotension after fluid bolus or whole blood lactate of greater than 4. Additionally, patients had to have 2 lactate measurements done in the emergency department, and they had to have an initial lactate level of greater than 2 millimoles per liter. We excluded patients who were less than 18 years old, had a contraindication to central venous catheterization, required immediate surgery, or had do not resuscitate orders. All patients received a structured resuscitation protocol targeting central venous pressure, mean arterial pressure, and either central venous oxygen saturation or lactate clearance. All patients received broad-spectrum antibiotics according to local institutional guidelines. The primary outcome for this study was in-hospital survival. The lactate kinetic parameters that we calculated included lactate normalization, defined as a lactate decline to less than 2 millimoles per liter. Absolute lactate clearance, defined as an initial lactate value minus the delayed value. Relative lactate clearance, defined as an absolute clearance divided by the initial value multiplied by 100. And the clearance rate, which was defined as the relative clearance divided by the clearance time multiplied by 100. We performed a univariate analysis between survivors and non-survivors using basic statistics. Area under the receiver operating characteristic curve was constructed for continuous lactate parameters to predict survival. Odds ratios for survival were calculated on categorical parameters using Fisher exact tests with 95% confidence intervals and adjusted for confounders using multiple logistic regression. Here are the results. We assessed 452 patients for eligibility, of whom 152 were excluded for the various reasons shown here, leaving 300 patients who were randomized. We excluded 113 patients post hoc for the reasons as seen, leaving 187 included patients for the present study. This table shows demographics and initial clinical characteristics. I'll call your attention to the fact that non-survivors were slightly older, had a higher creatinine, higher initial lactate, a higher initial SOFA score as compared to survivors. However, survivors were more often ventilated than were non-survivors. Here are the results of the receiver operating characteristic curve analysis. Absolute clearance had an area under the curve of 0.56 for predicting survival. Initial lactate, area under the curve of 0.64. Relative clearance, area under the curve of 0.67. And clearance rate, an area under the curve of 0.58. Because lactate normalization is a categorical variable, we calculated odds ratios to determine whether lactate normalization predicts survival. The adjusted odds ratios are shown here. Lactate normalization had an odds ratio of 5.2 to predict survival, while relative lactate clearance, 50%, had an odds ratio of 4.0. These were the only 2 kinetic parameters that were statistically significant in multivariate analysis. Limitations of this study include the fact that it was undertaken in experienced resuscitation centers and may not be generalizable. Lactate parameters are only useful in the setting of hyperlactemia, essentially excluding patients that have a normal lactate and a relatively small sample size. In summary, in ED sepsis patients undergoing early quantitative resuscitation, normalization of whole blood lactate during resuscitation was associated with the highest odds of survival than any other absolute value or absolute or relative change in lactate. Therefore, future studies should address if strategies targeting lactate normalization lead to improved outcomes. Happy to answer any questions you may have.
Thank you. This paper is now open for questions. And Alan, I'll start off with the first one while people make their way to the microphones. Did you look at the effect of which arm the patient was randomized to with regards to lactate parameters?
That's a good question. I've got a slide here. The treatment arm effect is obviously a potential confounder, so we included that in the multiple logistic regression and found that when we added it in, there was no significant impact on the model or on the resulting odds ratios that we reported.
Thanks a lot, Alan. Mark Cordy from Northwestern. My question is real simple. Can you comment on what the relative timing was for the lactate, two lactate levels, for instance, that the median time of one to the second, since it may not have been standardized, but it may give some clue to how to interpret the clinical significance?
Yeah. So, and that's a good question. I appreciate that. The second lactate was required to be drawn a minimum of 2 hours after the initial lactate was done and the resuscitation was started. And the median time for the second lactate was a little bit more than 2 hours, 2.3 hours. So they were done about 2 hours apart.
Fred KUT Houston, Alan, great paper. Thank you very much. Can you comment a little bit on the relationship of the lactate clearance to some of the more traditional variables that have been used to do early goal-directed therapy?
I suppose you're asking about comparing lactate to central venous oxygen saturation.
Yeah, exactly.
Yes. So there's only been 2 studies that have really addressed this issue in an experimental fashion. One of them is the parent study of this study, which showed non-inferiority of lactate clearance of 10% as a goal as compared to central venous oxygen saturation of 70%. The second study was done by Jansen and colleagues, and it included central venous oxygen saturation in both arms, but one of the arms had additional lactate-guided therapy. In that study, they targeted 10% per hour, 20% overall. Recently, the Surviving Sepsis campaign has adopted lactate normalization as their recommendation for resuscitation. And that I know of, this is the first analysis that shows that lactate normalization is truly the standard that we should be using. Right now, I still think that there are other studies that need to be done that compare central venous oxygen saturation to other parameters.
Thanks, Alan.
Well, thank you, Alan. And I'd like to thank all the presenters for today. I think it was a great, diverse panel of presentations. And right after this, we've got a Chicago-based pizza opening reception. So please head this way, and we'll see you there. Thank you.